Hi everybody. As I mentioned, my name is Alex. I'm an analyst at the Health Foundation. And I'm going to talk today about latent profile analysis, which is a form of cluster analysis applied to general practice staffing data. I'm going to focus primarily on the methods because we went through a process of deriving FTE, which is relatively new and unheard of, I suppose. And LPA as a model is also relatively underutilized, so we'll spend a bit of time on the two of those. In terms of the background, we can describe the context at primary care level as an increasing demand for care alongside fairly significant workforce pressures. That comes about through a number of kind of coexisting factors, namely failure to meet a couple of recruitment targets, change in the composition of the primary care workforce with GPs, elderly GPs retiring, change in people's preferences around work time, alongside fairly global increased demand for care in the form of aging populations, issues at social care level, and issues at secondary care level kind of overflowing onto primary care. One policy to address this was the additional roles reimbursement scheme, which is a policy that incentivizes the use of non-medical staff. So we'll keep that policy in mind when we come to our findings. The overall piece of work did include some descriptive work where we looked at contact rates across different deprivations and different demographics in different regions, but the focus of this talk is our cluster approach, cluster analysis. The data we were using was fairly broad. We used CPRD, which is primary care data. We had data from about 1,500 practices, 27 million patients, 2.7 billion contacts across an 8-year period, which was broadly representative at the regional and demographic, or in line with regional and demographic trends at the national level. So prior to constructing our model, we went through a process of deriving FTE. We could have used headcount in our data, but we know that there are a handful of inherent weaknesses around headcount, especially when certain members of staff work across a number of practices or less than full-time, for example, and we expected that those inaccuracies wouldn't be similar across all staff groups. They might affect some more than others. So to derive FTE, we had to also, first of all, estimate what number of contacts or consultations a staff member can do in a day that equates to a full-time day of work. We expect that that number would vary quite significantly by staff group. For example, senior GPs working with fewer but more complex patients, compared to healthcare assistants or nurses working with high volumes of relatively simple type consultations. So we started by plotting the daily consultation totals in a sample of 100,000 members of staff, and from that curve we extracted the 75th percentile to operate as our estimate or proxy for full-time working. And we also stratified that curve by deprivation and also by the practice population ethnicity mix, given that we expect them to be drivers for demand. So with our full-time estimate, we pull that back into our pooled contact activity, and we divide our contacts by our full-time estimate to give us an FTE proxy. We then aggregate that up to practice level, convert it to a rate to account for practices of different sizes, and that then becomes the input to our model. So a table of each of our practices and staff-specific FTE estimates. So latent profile analysis, as I say, is a form of cluster analysis, may well be relatively unheard of. Definition there, finite mixture modeling that applies probabilistic modeling techniques to determine if there are unobserved or latent variables having some type of effect on our data. So the key aspects of that, we feel, are that it has probabilistic modeling and, well, a little point over this, and an assumption of unobserved variables at play. So LPA falls on the right side of the slide here. So the LPA model will assess the distribution of all of our data and look for shapes that exist in that data. And the shapes that are present are the drivers of assignment to a certain cluster. Compared to on this side, for example, where we've got k-means, k-medioid distance measures, in which a certain point is assigned to an overall cluster based on the nearest central measure that it exists. Whereas theoretically, this point here, for example, could be closer in distance to this measure, or to this central point. So with k-means, it would be assigned to this blue cluster, but actually the model assesses its position relative to others around it, sees that it falls within a broader shape, and by applying probabilistic assignment, it would then be classified as this cluster. For the model to do that, it has to, again, rely on this assumption of unobserved variables being at play. So having selected our approach, our LPA approach, we fit each different type of LPA model to our data, and then we're led by goodness of fit measures as to which one to choose. So in this case, we're looking for the lowest BIC, so we would, in this case, select this VEV model, and then we have to tell the model what number of profiles or clusters to extract, which is a trade-off between goodness of fit with more profiles, or model simplicity and therefore interpretability. In our case, we select 6 profiles to extract from our data. So that's what the model does. The model gives you 6 profiles. One practice is assigned to one profile. And broadly, we can describe our profiles as one that is essentially high overall staff rate across each of our staff groups, 2 and 3 that have low overall staff rates but have a reliance on a single type of medic. Profile 4 has a kind of medical focus alongside healthcare professionals and advanced practitioners. Profile 5 has a higher rate of junior doctors relative to qualified medics. And Profile 6 is a broadly non-medical focus with reduced staff rates in the medical groups. So that's essentially what the model gives you. It condenses 6 different staffing measures into one cluster, and we can then quite quickly link our practice information, our practice level assignments to other practice level variables that we have. So we can start by looking at deprivation. So on the top here, we've got the distribution of deprivation across all of our practices, and then we can assess within each of our staffing profiles how deprivation is distributed. So for example, in the non-medical staff focus, we can see that practices from the most deprived quintiles are relatively underrepresented compared to practices from the most affluent quintiles relatively overrepresented, which might go against the idea that more affluent areas are overdoctored and more deprived areas are underdoctored, for example. Similarly, we can look at the distribution of our profiles within a certain geography. So at the national level, we see there are 8% of our practices are categorized as having a high overall staff rate, with 25% of our practices having a low overall staff rate and reliance on a senior partnered GP. However, in the southeast and the southwest, there is a lower number than you might expect of practices that were considered high overall staff rates. And in the East Midlands, for example, there are no practices that would be categorized as having a high overall staff rate. We can also quickly look at how the profiles compare against utilization of the roles that are captured in the additional roles reimbursement scheme. And it's not necessarily surprising that each of our 3 profiles that are broadly non-medical are also seen to have a high utilization rate of activity from additional roles. So that's the 2 are kind of correlated, but it's encouraging to see that our model is picking the 2 up. In terms of the way in which we evaluate this, so the process for deriving FTE is completely new, and the use of LPA is relatively new. So we hope that these type of studies can contribute to a body of knowledge in that area, but is obviously also open to criticism. A strength of the LPA, as with any cluster analysis, is that it gives you a quick measure which you can then link to other things. And finally, there's a couple of assumptions around the way in which we select our FTE percentile, our full-time estimate, which is open for debate. And similarly, there's subjectivity in the way in which we name our profiles, which, as again with all cluster analysis, that can then steer the reader or the kind of viewers as to how to interpret the findings. So it's important to take care in the way in which we name our profiles. That was a whistle-stop tour, but thank you.
Thank you very much. Did you examine how the size of practice related to the profiles? Sorry, I didn't read that at all well. I'm so sorry. How did you examine how size of practice related to the profiles?
Not explicitly, because we kind of controlled for it in that we fed the FTE rate into our model. So we would expect that variation to be kind of leveled out by looking at the rate of access per patient population. But we've looked at the size of practice relative to contact rates overall, and broadly similar across the kind of the middle of the range. It's the very small practices and the very large practices which tend to have lower access rates.
Is NHS England and ICBs accessing these results, and what are the future implications?
So this is for NHS England, and it's essentially the first kind of analytical output within a broader package of work. So the plan is to align staffing profiles with demand profiles and case mix type analysis to kind of cross-tabulate the three of them. So yeah, it kind of fits within a broader picture, and they're very much involved.
Is LPA distinct from latent class analysis?
It's the same thing. So latent class is kind of what they call it when they apply it to quantitative data, and latent profile is what they call it when it's quantitative data. So the same thing.
What are the features that fed into the LPA? Was it the counts of staff in each? Oh, so maybe these are separate questions that you might want to do for each one of them.
Yeah.
So what were the features fed into LPA? Let's start with that.
Which features?
Yes. Was it the counts of staff in each category or something else?
So it was the Z score for the staff staff rate per population. So it was just a measure of distance from the mean, essentially.
Okay. And how long would a process of work like this take to do?
Depends how good you are, I suppose. It took me a while. It's mostly, given that it's quite underutilized, it's more a process of doing that upfront learning. And then once you've kind of got your head around what it's actually doing under the hood, it's relatively straightforward. In most instances, you're led by the data. Through that process of goodness of fit measures, that type of thing, it's not impossible for anybody in this room or viewing.
Great work, someone says, but also to echo that, thanks for sharing. What variables were used to select the clusters, assuming that they were independent of the variables you were then comparing against?
Say that again, sorry?
What variables were used to select the clusters, assuming they were independent of the variables you are then comparing against?
So the clusters are essentially just functions of the staffing variables that we fed into the model. So we had a table of practice, ID, and then a table per staff group. So we had 6 variables that fed into the clusters, 3 types of medics, a nursing staff rate indicator, healthcare assistant, and then other healthcare professional. So those 6 variables then became a composite variable, i.e. the cluster.
And it says, are you willing to share your code for others to use, or is it already available online?
It's not available at the moment. I think it will be available via the Health Foundation GitHub, but we're also going to have to publish this in an academic journal, so the results will be accessed via that route as well.
You're getting loads of questions. This is fantastic. Keep going. What other uses do you have in mind for the clusters?
Well, it's a pretty open. Once you've kind of worked through the process of generating the clusters, then the way in which you then link them is kind of very open to whoever picks up the piece of work. Originally, the plan was to assess them against demographic and regional variables, but also look at clinical and operational outcome variables within CPRD. The CPRD environment is relatively constrained, given that it's a product that services pay for. The one possible aim is for us to export an algorithm that can essentially be applied to other data sets that would apply the same clustering, which would then open us to linking to any type of practice level indicator you can think of, really.
And do you think it could be fitted into an A&E environment, looking at staffing mix, deprivation, etc.?
Almost certainly, yeah. It would have to take some thinking around, but yeah, it's not at all confined to a certain type of data or a certain setting.
I noticed that you used quintiles. Was decile information on deprivation available to you, or was that something that wasn't available?
No, it wasn't available within CPRD. Given that when you work with CPRD, you're fairly beholden to the data access that they allow you. But again, if we can export the clustering algorithm, then we could apply it to deciles without any issue.
We have one final question, I think. Do put some more questions in that we can reply later. Are there any specific data sets, such as this one, where latent profile analysis would be better than other cluster methods, for example, k-means?
I don't think that's necessarily a question of the data set. That's more your assumptions going in beforehand. If you expect there to be other variables at play on the data that aren't included in your model, then you would tend to kind of move towards LPA. K-means simply measures the variables that you input to the model based on that distance measure. So it's kind of, I think it's more a function of your understanding of the data prior to even creating the model.
That's it. We've given you the grilling.